Do you have your computer just so I can check the link? That could be fine. What did you do? I put an L to make it Y. Yeah, awesome. Let's see if the sound's working. Sound.
I felt bad that I couldn't come out.
What are you listening for? I'm just seeing if the our voices appear on here, just to know if the sound's working.
Yes. Oh, right.
Yeah, the sound's working. I think so. Yeah.
Hey, how's it going?
So
Is it similar to the one you?
no,
Okay, there's
different to that.
wait,
The one
I
did. Yeah, it uses parts of
your dad
ones I guess.
looks exactly like you. And you also talk the same.
Really?
You're basically the same person. Which is a bad thing. I mean, all the guys, all the obstetricians, they're like, oh, right, Kashyap, yeah, he's so good.
Yeah. Okay. Do you want to? Did you want it to just see if everything's there, or? Yeah, that'd be good. That should. Oh, it's on. It's only no. Yeah. I can't use my. Do you want me to use it? Yeah. So. I was trying to check none of their boxes yet. Yeah, so they have. What was that? Well, the boxes have moved. See how the pictures are. Because the text must be different. Or I'll see. Was it all right on the PDF you sent me? Yeah, but I need the animations. Okay, yeah. Okay, so it's going to be. But it must be only like the text must be a little bit bigger.
Yeah. Okay. You take your time. We can wait.
If I write it now and get like distracted.
Yeah.
I'm
yeah. There's another USB.
Oh, that was Aidan.
Windsor. We'll just
start.
yeah, Jude, I'll just post up the things to Facebook so that people
Try to get
yeah.
Most people want to get it at 6 or 7.
Yeah, it's 6:05. We can wait like another 5 minutes if you want. Or,
And that makes sense.
yeah, they usually turn out like 5-10 minutes after.
Yeah, we'll wait.
Just have a look if anyone's out. So.
Just press present.
Yeah, and it should be good. Get everything like the next slide. Yeah, thanks. There's no one waiting outside, so you could just start. Might do a little bit of an introduction if you want.
How you doing?
All right, guys, we'll make a start. Thanks for coming. So today we're having labour, birth and obstetric emergencies by Aidan, so make him feel welcome.
All right, hey everyone, my name's Aidan. I'm talking about labour, birth and obstetric emergencies. So I think when you're learning women's, it's really important to get a basic understanding of everything behind the condition first, and to do that you need to read the books. Gareth Weston's OSCE book, even though it's very OSCE focused, has a lot of great explanations in it, so that would be the first thing I'd read. And then there's a lot of other resources out there that I've listed. But in order to answer your exam questions and do well in your OSCEs, you really need to start looking at guidelines. I've listed a few here. The Monash health ones are probably what you need to look at if there's something contentious, because most of the doctors who write your OSCEs and exams are from Monash, so they'll be following them. But the South Australian health guidelines are probably the best in terms of having really nice flowcharts to look at. So I'd encourage you all to look at them. So first of all, I thought I'd talk about why this kind of stuff's important, why we need to know how to manage labour and delivery. And it's because one of the biggest differences between the developed and the developing world is in maternal and neonatal mortality. And that's why we have so much better life expectancy rates. So it's really important to know how to appropriately manage labour and delivery. So normal labour is the spontaneous onset of labour at term, which is defined as between 37 to 42 weeks gestation, but probably differs depending on the person's background. It'll probably change for women who are, for example, from Southeast Asia or India. It's defined as progressively more painful and more frequent uterine activity that results in progressive effacement and dilatation of the cervix. So everything you need to get a baby out. The baby normally presents in a vertex position, which we'll talk about in a second, and the mum's healthy and the baby's healthy as well. So labour spontaneously occurs because in the last few weeks of pregnancy, the mum's uterus starts to get ready to expel the baby. So in normal women, the uterus doesn't really contract as a whole. Different bits of the uterus contract at different times. But in the last few weeks of pregnancy, the uterus starts to try and contract together. And if you've got a spare 5 minutes, there's a really cool video about how this works that I encourage you to look at. And the cervix also gets ready to let a baby out, so it gets more water and less collagen, so essentially can stretch better. The second thing that happens is this is a sheep from it's a lamb that's been born to a mum that had the herb cyclopamide, which is a teratogen that leads to them only having one eye, hence the cyclops, but also inhibits pituitary development. So recognising that these lambs weren't actually born, they were only ever delivered by caesarean section, was what first got people interested in realising that it's the fetal HPA axis that triggers labour, and it's not actually the mum. So the fetus is what's trying to get out rather than the mum trying to push out the baby. So the most important variables to think about in labour are the 3 Ps, the passenger, which is the fetus, the passage, which is the maternal pelvis, and the power, which is the uterine contractions. And when thinking about why labour might not be working properly, you need to consider these 3 variables. So what can go wrong with the passenger? Well, first of all, you need to know how to assess what the fetus is doing in there. So in order to assess it, you need to describe it properly. You need to describe the lie, which is the long axis of the fetus versus the long axis of the mother. So it can be longitudinal, which is vertical to vertical, or transverse, which is horizontal to vertical, or oblique, which is diagonal. Longitudinal is normal. Then you need to think about the presentation. So presentation is which part of the fetus is coming out first. Normal, it's cephalic, or the head, but it can also have things like a shoulder presentation, breech, which is bum or feet, or face. Next is the attitude, and the attitude is really how much the fetal head is flexing. Normally, it's completely flexed, and this allows the fetus to present the vertex of its head to the maternal pelvis, and this allows it to have the narrowest diameter, but it can range all the way to full extension, which is what happens in a face presentation. The last thing to think about is the position. So the position is the relationship of the denominator to the pelvis. The denominator is usually the occiput, and so left occiput anterior is normal. So this is when the occiput is pointing to the maternal left and to the anterior. So that means the face is pointing towards the bum. So when thinking about the maternal passage, when things that go wrong are something in the way of the baby coming out. So maybe the placenta's in front, like placenta previa, maybe the mum has fibroids in the uterus, or maybe the baby's head is too big for the mum's pelvis. So thinking about why a flexed vertex presentation is best, it's all got to do with the diameters of the fetal head and the maternal pelvis. Oops. So the fetal head, when it's flexed, its diameters are 9.5 and 9 centimetres, whereas when it's a brow presentation, it's 12.5 and 9 centimetres. Thinking about what the maternal pelvis is, its smallest point is the outlet, which is 11 by 10 centimetres. So clearly a brow presentation isn't going to fit very well, but a flex presentation is. So that's essentially why a flex vertex presentation is best. The last thing to consider is the power of the uterine contractions. So there's a few ways we can describe this. We can describe the frequency of contractions. Normally it's 3 to 5 contractions per 10 minutes. If it's lower, it can lead to, it's not enough to dilate the cervix appropriately. And if it's higher, it can distress the fetus, because during a contraction, the uterus is contracting. So everything in the uterine walls is getting squeezed. And obviously the mum is giving the blood to the fetus. So when the walls are squeezing, no blood can get through and the fetus isn't getting any blood. So the baby needs a bit of time to recover between contractions, essentially. We also need to think about the intensity of contractions. The minimum required to be effective is 25 millimeters of mercury, but the optimal is 50 to 60. You don't really need to know those numbers. You need to assess the duration as well, so how long each contraction is going for, because as I said, during a contraction, the fetus isn't getting much blood. When assessing the contractions, we can do it subjectively by palpating the fundus of the uterus, or we can do it objectively using a tachometer. But just knowing the contractions doesn't really tell us a whole lot. We need to integrate it with our knowledge of the fetal heart rate, and that's what a cardiotocograph is. So this determines how the fetus is responding to those contractions and seeing how it's reacting. So when thinking about what actually happens in labour, I think you need to break it down to pre-labour, the first, second and third stages. For pre-labour, you get these things called Braxton Hicks contractions, which are kind of like fake contractions. So they're short, irregular, not very intense at all, and they're more of a groin discomfort, whereas in true contraction, there's a discomfort in the woman's back. And most importantly, there's no cervical dilatation during Braxton Hicks contractions, and that's what will differentiate them from true contractions. The woman may also feel this experience of lightening, where the baby begins to drop down, so they can suddenly breathe a little bit easier, but they feel this urge to urinate, as you can imagine. The mum may also have a bloody show. So just the cervical mucus becomes a little bit blood tinged. It's not frank blood or anything, but it's a little bit blood tinged. So danger signs to look for in pre-labour are when the contractions are very frequent, so under 5 minutes apart for an hour, but there's no cervical dilatation yet. When there's gushing fluid or a constant leak, which may indicate a rupture of membranes. When there's bleeding, obviously, or if there's any decreased fetal movements. And these are all things that might make the pregnancy high risk, and you'd start to monitor appropriately. So the membranes usually rupture at the beginning of labour, but not always. We'll talk a bit about that later. It's usually a large gush where there's about 50 to 300 mils, and then a continuous slow leak throughout the delivery process. So true labour commences when there's progressively more painful and frequent contractions and effacement and dilatation of the cervix. So it can be the first stage of labour can be split into the latent phase, which is the first 4 centimetres of cervical dilatation, and the contractions are still quite irregular and slow. In the active phase, which is the next 4 centimetres, the contractions are more regular and rapid. In nulliparous women, the cervix should be dilating during this phase at 0.5 centimetres per hour. In multiparous, it should be going a bit faster. The transitional phase is the last 2 centimetres of cervical dilatation before the woman's fully dilated. During this phase, the mum feels very out of control, gets very emotional, will probably start shouting at her husband, asking for an epidural. And during this time, the best thing to do is to try and keep her calm by focusing on breathing and encouraging her to moan and let it out. So in a nulliparous woman, this first stage usually takes about 12 hours, and in multiparous about 6.5. Once the active stage is defined, so that's on vaginal examination, because it's about the cervical dilatation, you begin recording notes on the partogram, which we'll talk about in a second as well. So the second stage is from when the woman is fully dilated until when the baby is delivered. This is split into a passive phase, in which the presenting part just naturally descends, and an active phase, in which there's maternal effort required. The mum has to start pushing. So once the baby's head is visible, it's really important to stop the mum pushing. You just want her to start panting it out rather than pushing. So in a nulliparous woman, it needs to occur within 2 hours, otherwise it's failure to progress. And in a multiparous woman, it needs to occur within 1 hour. If the mum's had an epidural, you add 1 hour to both of those. So the third stage of labour is from when the baby is delivered until when the placenta is delivered. This normally is complete within 30 minutes of delivery, but now everywhere in Australia we do active management of the third stage, which means that we actively try and get the placenta out. We'll talk about that in a second as well. So we're thinking about what happens during delivery. Essentially, it's an egg going through a complex 3D oval shape. So rather than trying to explain it using my hands, I'm just going to show a video because I think that does a better job. Hopefully the sound plays through. Will it play through? I don't think it needs sound anyway. So essentially you can see the baby descending. So the AP, anterior posterior is the narrowest diameter at the inlet. So the baby's head has to be sideways to get through that narrow diameter. So there's descent, the baby's head engages. I don't know how slow it'll go. Then the baby's head has to flex to get that vertex presentation. So you're seeing that happening now. It's a really good inside look. And then internal rotation needs to occur. So this needs to occur because the diameters of the pelvis are changing as it moves through. So you can see it's internally rotating here towards the midline. Let it keep going. It's normally a lot slower than this as well. So once the baby's head is out, it needs to extend. Just to curve around there. And then the head needs to straighten up. And then you deliver the shoulders. I'll let you watch that at home as well. It's probably good to be able to explain it yourself in an OSCE, and I think watching the video a few times is the best way to do that. Okay, so how do you manage a normal labour? Labour is obviously natural events being occurring for the whole time humans have been alive, so you shouldn't really have to do much if everything's going normally. One of the biggest things you can do is give emotional support. It decreases the amount of pain the woman's feeling, improves outcomes for both the mum and baby, and it makes it a whole much less stressful experience. What your role is to do is to provide surveillance and be wary for something going wrong, and so you can do something immediately. So we do that by recording our findings on a partogram and by taking a history, which involves an obstetric history, and asking for risk factors or any previous complications during pregnancy, performing an examination, so vitals, abdominal exam and vaginal exam, and reviewing the previous examination, so the previous blood groups and rhesus status. And if they're low risk, you only need to intermittently auscultate the baby for the fetal heart rate, whereas if they're high risk, it needs a continuous CTG. But the key thing here is that not every baby needs a continuous CTG. The other big thing to do in the first stage is to manage the mum's pain, which we'll go into in a second as well. So some babies are low risk going into the pregnancy and some are high risk, but during the delivery, this can change. So the things that can change a baby from being low risk and only requiring intermittent auscultation to being high risk and needing continuous CTG, or if there's failure to progress, which we'll talk about, or if there's fetal distress, which we'll talk about as well. So on the partogram, every 30 minutes, you need to be recording the contractions, their frequency and strength, the maternal heart rate, the LICOR, and the fetal heart rate. Every 4 hours, you do the rest of the maternal observations, including blood pressure, and do a vaginal exam. In the second stage, you need to do these more frequently, so do BP and BE hourly. So managing pain, labour pain, as I said before, is usually felt kind of in the lower abdomen and back, and it increases as the cervix dilates for obvious reasons. For everyone, you can, as I said, give them emotional support, but for most women, they're actually going to need more than that. As with any pain situation, you need to go up the pain ladder. Start with any non-medical forms, move to patient-controlled analgesia, then prescribed analgesia, and then anaesthesia. So non-medical pain management includes a lot of things like intermittent bathing, allowing the mum freedom to walk around and find a comfortable position, massage and breathing exercises. The advantage of these is that obviously there's no medication, so there's not any side effects. The patient feels very in control and the partner can get involved because you don't need any training to do a massage. So the disadvantages are that unfortunately it's not adequate for most women. If the woman's bathing, you can't use CTG, and if they're moving around, the CTG doesn't work so well. So most women actually require patient-controlled analgesia, and you've probably seen most women on board having the NO gas or the TENS. So the two patient-controlled analgesia to learn are nitrous oxide and TENS. I would probably go through and learn all the advantages and disadvantages of each pain thing because it's a very easy OSCE for them to give you, but I don't quite have time to go through it all today. Essentially, moving up the ladder, it becomes more side effects, but more effective. So think about prescribed analgesia. You can give things like Panadol or intramuscular pethidine. The advantages of this is that it's better analgesia than patient-controlled and it's quite routinely available. However, unfortunately, you start to see more side effects, as I said. If none of this is working, you can then think about anaesthesia. So an epidural is a continuous infusion into the epidural space. So as the nerves move through that space, they get blocked. And so at a low dose, an epidural actually blocks pain fibers more than motor, and this is really what you want. So in order to reduce the dose of bupivacaine we require for local anaesthetics, we can use an opioid as well, and that means that the mum might still have some motor ability left. A spinal anaesthesia is a single injection rather than a continuous infusion, and it's straight into the CSF. This has a faster onset, but it can lead to a bad headache for the mum. You can also offer combined spinal and epidural. So the advantages are that it's the best pain relief, but obviously it has lots of disadvantages in that it requires a specialist anaesthetist to come and do it, requires IV access, CTG monitoring and a catheter because there's not much motor, and it has a lot of side effects, which I'll let you read through as well later. I won't go through anaesthetic emergencies, but I put it in there for completeness. So in the second stage of labour, you need to just allow time for the fetus to passively descend. So allow about 1 to 2 hours, as we said before. And this increases the chance of the mum having a spontaneous vaginal birth and decreases the risk of an instrumental delivery, which is associated with a lot of risks we'll go into later. It's very important to allow women just to be guided by their own urge to push, so let them choose when to push. But when they are pushing, it's very important to encourage them to push for longer and for harder. Of course, you can monitor the advancement of the presenting part and make sure it's all progressing fine. During the second stage, you auscultate more frequently, you do VEs more frequently, and blood pressure more frequently as well. I don't think I said before, but when the head's delivered, you need to gently tilt the baby towards the mum's bum so the anterior shoulder can come out first, and then tilt the baby towards the mum after so the posterior shoulder can be delivered. In the third stage of labour, which is from the delivery of the baby until delivery of the placenta. In every Australian hospital, we now do active management to reduce the postpartum hemorrhage risk, which we'll talk about later. So active management at Monash is syntocinon given 10 international units IM at delivery of the anterior shoulder. And if there is significant PPH risk, you can give ergometrin at the same time. They say to clamp and cut the cord within 2 minutes, but there's some research looking into delayed cord clamping as well. And then apply controlled cord traction. So this is where you just slowly provide traction on the cord. You don't rip it out. That would damage the uterus and placenta. But you just apply some pressure and apply traction on the cord. Once the placenta does come out, it's really important to check that it's complete and there's no retained products in there. So that's normal labour, but obviously some things can go wrong in labour, and that's why we have obstetricians. So thinking about what can go wrong, either it starts too early, doesn't start at all, it starts and then stops, or it starts and it's just too much for the fetus. So if it starts too early, as we said before, the membranes usually just rupture after the onset of contractions, and that's called spontaneous rupture of membranes. That's normal. Sometimes we need to artificially rupture them. That's artificial rupture of membranes. But sometimes they rupture pre-labour, before contraction. So that's pre-labour rupture of membranes. If there's pre-labour rupture of membranes, the first thing to do is to confirm it using a speculum, and then think about, does the mum, is GBS positive? Have they been ruptured for over 96 hours? Is there meconium in the liquor, so that indicates fetal distress, or is there any evidence of intrauterine infection? If there's yes to any of these things, you need to induce her straight away. Apply a continuous CTG because it's high risk, and give her benpen if she's a GPS positive. If no to all of these things, then you expected management is okay for 96 hours before you have to start inducing. You want to determine her GBS status and review her at 24 hours and encourage her to contact you if she's worried. So pre-labour rupture of membranes that occurs before 37 weeks is preterm. So we call that preterm pre-labour rupture of membranes. So if they're very preterm, if they're below 35 weeks, we give them corticosteroids. You give all of these patients IV benzylpenicillin and oral erythromycin. And if there's contractions, we want to give some tocolysis, so we can give oral nifedipine. There's more information on preterm birth in a lecture I think you've already had. So the second thing that can go wrong is that the labour just doesn't start. So when thinking about when this is actually a problem, we need to think about when do we want the labour to start. So when do we want to induce a woman? So essentially we need to induce a woman when the risks of continuing a pregnancy are greater than the risks of delivery. So there's some absolute indications that are maternal, such as when they've got GDM with complications, if they've got a pulmonary embolism, or if there's been any isoimmunisation. There's some fetal indications as well. If the baby's IUGR, there's evidence of chorioamnionitis, if there's prolonged PPROM, if it's post-term, or if there's been a placental abruption. There's also some relative indications for induction that you need to consider. There might be an antepartum hemorrhage, as we'll talk about later, pre-labour rupture of membranes, macrosomia, or oligohydramnios. There's also some times when you shouldn't induce, and these are if the mum has active herpes, if there's malpresentation, if there's fetal distress, if there's a past cesarean section, vasoprevia, or placenta previa, or a prolapse. Yeah. We'll go into that's one of the obstetric emergencies. We'll go into it. It's essentially when the fetal vessels are before the presenting part, and so we don't want to induce because we don't want the mum to push it out and cause the bleed in the fetal vessels. So how do you induce someone into labour? The first thing to do for all women in which you're planning a formal induction is a stretch and sweep. So this essentially means you use your finger to stretch the cervix open and then sweep the amniotic membranes from within. And this releases prostaglandins and can sometimes induce the mum into labour. So this, as I said, this is offered prior to any formal induction because it's not very dangerous at all. It's offered at a 40-week visit to nulliparous women, and it's offered at a 41 visit to multiparous women, but it's not required at those times, just offered. After a stretch and sweep, if that doesn't work, you then need to assess whether she's favourable to induce formally. So when assessing favourability, you use the Bishop's score. This is the full Bishop's score. There's also a modified Bishop's score, which might be worth looking at as well. But I'll just go through this for now. Essentially, all you need to know is that a high score means she's favourable, so you can induce her, and a low score means she's unfavourable, so you need to ripen first. You also need to know a little bit about what each of the things are you're assessing. So first of all, you need to look at cervical dilatation. So clearly there's a big difference between a closed cervix and an open one. So obviously an open one is what we want. So higher dilation is a bigger Bishop score, so it's more favourable. You then need to think about the cervical length. So this is a little bit more you've got to think about. Essentially, in order for the cervix to open, it needs to thin a bit, and in order to thin, the length has to decrease. So a lower length is a better Bishop score. Okay, so she's more favourable at a lower length. The next thing to think about is the consistency of the cervix. Obviously, to let a baby out, it has to be pretty soft. So the softer it is, the higher the score. And then the position. So the position is actually referring to the cervical position. So how the baby is positioned relative to the cervix. So whether it's presenting kind of at the back of the cervix or in the middle or at the front. So at the front is what you want. The last thing to think about is the station. So I'm sure you all know that the station is 0 at the ischial spines, and a negative station is above that, and a positive station is below that. So obviously, the higher the station, the more positive, the more favourable it is because it's getting ready to deliver. Okay. So once you've determined whether a woman's favourable or unfavourable, if she's not favourable, you need to ripen her before inducing. So ripening involves giving vaginal prostaglandins. So you can give it as a gel, which is 2 doses over 6 hours apart, or a pessary, which is just putting a pessary in and leave it in for 12 hours. So the risk of inducing this, of ripening, is uterine hyperstimulation. Obviously, you want to stimulate the uterus a little bit. That's what the whole process is doing, trying to stimulate contractions, but you can stimulate it too much. So after you've given the gel or the pessary, you can't give oxytocin soon after, and you can't rupture the membrane soon after. There needs to be a little bit of a gap period in between. If the woman goes into labour or has spontaneous rupture of membranes, you need to remove the pessary, otherwise it's too much for her. Misoprostol is a lot more effective than prostaglandins, but it has a 3 times higher risk of uterine hyperstimulation, so it isn't used instead of it. So once you've ripened, or if she was favourable to begin with, you can then proceed to artificial rupture of membranes and then begin an oxytocin infusion. It's really important not to give oxytocin to multiparous without asking a senior obstetrician first, as the delay in their labour may be due to something else. So when you're giving oxytocin, you first put 10 units into a 1,000 ml saline bag and then start with a very slow infusion rate, so she's not getting much to start with, and work your way up as high as you need without causing any side effects or fetal distress. If you're unable to ripen, it's a failed induction, and this means you need to perform a caesarean section. If there's fetal distress at any stage of the induction, you may also need to consider a caesarean section as well. Yep.
So in between the AR and oxytocin, you do this like together, or is it, sorry,
it depends on the situation, but yeah, usually you can just do an ARM and maybe wait 30 minutes to see if anything happens, and then oxytocin, but we'll come into it later, and there's some situation where you need to wait longer. So what are the risks of an induction? You can have excessive uterine activity or fetal distress. You can have uterine rupture. They may sometimes require a caesarean section. You can have postpartum hemorrhage more likely after an induction, and there can also be a prolapse as well. So the first two, excessive uterine activity and fetal distress, if you have both of them, it's called uterine hyperstimulation. So in order to manage uterine hyperstimulation, you first need to stop any oxytocin infusion they're being given, put them in the left lateral position, give them hydration IV fluids, take a scalp lactate from the fetus to determine its status, consider tocolysis, but don't always give tocolysis, and consider an emergency caesarean section depending on the fetal state. So the second thing that can happen is that the labour starts but then doesn't progress well. So this happens in the first stage. It's defined as when there's less than half a centimetre of cervical dilatation per hour. As I said before, it can be due to the fetus being too big for the pelvis or the pelvis being too small for the fetus. It can be due to presenting in the wrong way, the contraction's not contracting well enough, or something in the way. So these are, as we've said before, this is the kind of the passage, the passenger, and the power. So these are the kind of things you need to think about when something's going wrong. The first thing to do is to continue to encourage the mum. Sometimes that's all it needs. If that doesn't work, you can do an amniotomy, and then wait 2 hours and then perform the vaginal examination and begin, if she's still not progressing that first stage, give an oxytocin infusion. So see, it's a little bit different when we've got failure to progress versus when we've got an induction. In the second stage, it's defined as when the presenting heart stops advancing in a nulliparous woman after 1 hour and a multiparous woman after 30 minutes. It's because for the same reasons as before. However, by this second stage, the mum may also be exhausted, or she may have been giving epidural, which has led to ineffective pushing. The first thing to do is begin a CTG, do a vaginal examination, and then as before, amniotomy, give oxytocin unless they're a multiparous woman, and then consider an instrumental delivery if this second stage delay occurs in a nulliparous woman for more than 2 hours or a multiparous woman for more than 1 hour. And if there's an epidural, you can add on an extra hour to that. So the reason why we're trying to get the baby out if there's a prolonged second stage is that if there is a prolonged second stage, it puts the woman at much higher risk for a lot of different things such as PPH, pyrexia and postpartum infection. So the other thing that can go wrong is the fetus maybe doesn't present properly, and that can sometimes lead to a failure to progress. So some unusual presentations are if there's an occiput posterior, so that means the face is pointing towards the front, or an occipito transverse, so that means the face is pointing towards the side. These are bad because these, as we said before, these diameters are kind of too wide to fit through the pelvis appropriately, so there's an increased risk of prolonged labour and trauma to both the fetus and the mum. Another unusual presentation is if the face comes out first or the brow comes up first, and that's usually doesn't come out, so it usually requires a cesarean section. Some other presentations that are unusual if you have an abnormal lie. So if you have a breech birth, at 28 weeks, 20% of babies are breech, so bum first, but at term only 4% are. So the majority of these actually turn spontaneously, but some of them have an external cephalic version. So this ECV should be offered at 36 weeks to any woman who still has a breech birth at 36 weeks, because if it hasn't turned by then, it's probably less likely to turn in the next couple of weeks. A persistent breech birth is bad because or it can be due to kind of an abnormal anatomy, abnormal placentation, or an abnormal amniotic fluid volume, or just bad luck. And it's bad because it increases perinatal mortality and morbidity. The safest option for breech babies, if they can't be turned with an ECV, is to do a planned cesarean section at 39 weeks. But if they're not a very severe breech, you can sometimes do vaginal delivery if the mum wants it, but you would always recommend a cesarean section as being safer, I think. So there's 3 different types of breech. There's frank, which is when the hips are flexed and the knees are extended, so the feet are up near the face. There's complete, which is when the hips are flexed and the knees are flexed, but the feet are at the level of the bum. And there's footling, where the feet are below. So in frank or complete, you can do a vaginal birth if the mum wants it, and in footling, you always have to do a cesarean birth. Another unusual presentation if there's an oblique or transverse lie. So this can happen in a multiparous woman because the uterus doesn't quite have the same tone as it would otherwise, or if there's placenta previa because there's more space for the uterus for the fetus to swim around in. To manage this, you need to attempt to stabilise it in the cephalic position prior to delivering, but if you're unable to do this, you need to do a cesarean delivery. So we'll start doing some questions. So 24-year-old primary gravida presents at a routine antenatal visit at 37 weeks gestation. Pregnancy has been uneventful so far, and an abdominal examination revealed a single twin fetus in the longitudinal lie. Some physiofundal height was 36 centimetres, which is fine for her gestation, and she had a breech presentation with a mobile presenting path. So, Yoni, what would we do?
Sorry, I just went down. Well, I'll give it a go. All right. So.
So what do you think? ECV, yeah, so J is ECV, so that's correct. So yeah, I guess the things to look for is that the problem is that it's breech. If it's breech, you need to look at the time. If this 37 weeks had been like 28 weeks, the option would probably be don't worry about it, just wait, see if it turns, do another scan at 36 weeks. If it had been 39 weeks, it would have been delivered by a cesarean section, but because it's 36, 37 weeks, it means you can try an ECV first. So that would be the answer. So next thing that can go wrong is if there's fetal distress. So low-risk pregnancies only require intermittent auscultation during labour, like we said, but there are some warning signs on that intermittent auscultation that can make it become a high-risk pregnancy. So if there's fetal tachycardia or if there's periods of bradycardia after a contraction, it's a warning sign that it's becoming high risk. You need to start doing continuous CTG. So, on a CTG, I'm not going to go into it heaps. You can look at it. There's a good website I'll put up in a second to go through it properly. But the normal values in CTG are a rate of 110 to 160 beats per minute, variability of between 6 and 25, and accelerations occurring every 15 seconds for 15 beats per minute. So when you're reading at CTG, you need to do Dr. C Bravado. There's a link here that goes through it all properly. But essentially, first of all, define the risks. So are they a low or high risk patient to start with? What's been going on in the pregnancy so far? And so you can put it into context. Then assess the contractions. So when are the contractions occurring? How often are they occurring? Look at the baseline rate, then the variability, accelerations, decelerations, and then put it all together for your overall impression. So variability, I put a picture there in case anyone didn't realize, it's kind of how much it's deviating around the baseline. So some signs of fetal distress on the CTG are a change in the baseline, so an increase. So over 160 can be due to things like infection, and under 80 is a non-reassuring trace, and it means you've got to, it just means the fetus is possibly in distress or something's gone wrong, which we'll talk about in a sec. If there's reduced variability, it's also a sign of fetal distress. So for a variability between 0 and 3, we call that absent variability, and 3 to 5, we say minimal variability. Decelerations, which we'll go into in a second as well, are also a sign of fetal distress. The thing to remember is that the CTG is very sensitive, but it's not very specific. So if there is an abnormality on the CTG, it's best to do a fetal scalp blood to confirm if there's any fetal distress or any fetal acidosis. So there's 4 different types of decelerations here. The first one is an early deceleration. So this is when there's kind of a symmetrical rise and then a gradual decrease, and it's occurring kind of exactly symmetrical to the contractions. So the peak in the deceleration is occurring at the contraction. Sorry, you can see. Whereas in a late deceleration, there's a gradual decrease, but the lowest point is after the peak of the contraction. Okay, so the dangerous one is the late. It's non-reassuring, and it's probably due to uteroplacental insufficiency, whereas an early deceleration is just physiological and it's probably fine. Another type of deceleration is a variable deceleration, where there's an abrupt decrease, and it doesn't really matter where the contraction is. The deceleration can kind of occur anytime. That's why it's called variable. And that's due to cord compression or oligohydramnios. So there's not enough space in there, so it's compressing the cord. There's also prolonged decelerations. So if it's going on for over 2 minutes, it's non-reassuring. If it's going on for over 3 minutes, something's definitely wrong. Okay. So another type of trace you might see in a CTG is a sinusoidal trace. This is quite rare, and it's usually a sign of severe fetal hypoxia or anemia or hemorrhage. So if you see a sinusoidal trace and it's confirmed, you of course first call for senior help, and then it's probably best to do an immediate cesarean section. So we'll talk a bit now about instrumental delivery and why you would need to do it. So instrumental delivery between 1995 and 2004 made up about almost 10% of deliveries in Australia. And clinically, we're now seeing more use of the vacuum rather than forceps, and the training patterns are changing because of that. It's very important too, when you're delivering using instruments, to coordinate your pulls with maternal pushing, so you're not doing any extra work you don't have to. And if you're anticipating it to be difficult, you want to do a trial of forceps in theatre. So don't try it in the delivery room, take it to theatre first, try the forceps. If they don't work, you can immediately do a cesarean section. Because obviously it's very distressing for the baby to have an instrumental delivery. So in order to do an instrumental delivery, you need to meet a few key requirements. The cervix has to be fully dilated, so she has to be in the second stage of labour. The fetal station has to be at or below the ischial spines. The fetal head has to be fully engaged, and the exact position of the fetal head has to be known. So the indications for an instrumental delivery are if the mum is exhausted or has a medical condition and can't spend that much time in labour, so she might have some cardiovascular abnormalities, or if the second stage is going on for too long. There's also some fetal indications, so if the fetus is in distress or if there's a cord prolapse, which we'll talk about later. The risks of instrumental delivery, so for both vacuum and forceps, are peritoneal trauma is more likely and more severe. For the fetus, it can have a retinal hemorrhage, a cephalohematoma, or a subgaleal hemorrhage. The contraindications for instrumental delivery are if there's a bleeding disorder in the mum, if there's some form of bony demineralization, such as osteogenesis imperfecta, or if the fetus is too big, So when we're classifying instrumental deliveries, we need to think about kind of the position of the fetus. So an outlet instrumental delivery is when the scalp is visible and the skull has reached the pelvic floor. So the sagittal suture has to be an AP position or an ROA or LOA, and the rotation is less than 45 degrees. A low forceps would be when the skull is at station greater than 2+, but might not have reached the pelvic floor yet, and it can occur at any rotation. A mid forceps is defined as when the skull is less than 2+, but is engaged, and a high forceps is if the head is not engaged, so if it's above the ischial spine. So these are not performed. So it's very important that if this is some kind of OSCE, which don't think this part of it would be an OSCE, but if it is, you'd want to make sure you say, and I made sure to determine there wasn't any caput or anything, caput, sorry, because that can make it appear, the head appear lower than it is, obviously. So thinking about forceps, in Gareth Weston's book, he goes through the different types of forceps and how to describe them. He said it was once in a monash OSCE, but I feel like that was 10 years ago, so I don't know if they'll do it now. But maybe it's worth looking over kind of what each part's called and at least knowing what the different types of forceps are and when they're used. So Wrigley's forceps can only be used during an outlet forceps. That's why I described it before. Keelan forceps are good because they can rotate the fetus. So if the rotation is greater than 45 degrees, it's okay. And Neville Barnes forceps can only be used in an OA position. So the risks of forceps, on top of the ones we talked about before for all instrumental deliveries, from the mum, there's a high risk of vaginal lacerations, perineal injuries, urinary retention or PPH, and long-term, she can have incontinence of feces or dyspareunia. Fetus, you can have scalp or face lacerations, a cephalohematoma, subconjunctival hemorrhage, facial nerve injury, skull fracture, or shoulder dystocia. For vacuum deliveries, the risks are very similar, but there's less risk of perineal trauma, but increased risk to the neonates. It's a bit of a trade-off. The other things with vacuum is that you can't use it in preterm babies under 34 weeks, and you can't use it with a face presentation because you obviously can't apply the cup to the fetal face. So perineal trauma is a big complication of instrumental deliveries. A first-degree tear is just injury to the skin. A second-degree tear is injury to the muscles underneath. A third-degree tear is injury to the muscles even deeper, so the anal sphincter muscles. And a fourth-degree tear is injury to the mucosa inside the rectum. So it's obviously gone very, very deep. I'll talk a little bit about caesarean section, but I won't give a complete overview. So the indications for an elective C-section are if the labour is going to be detrimental to either the mum or the baby. So if the mum's had a previous caesarean section, if she's had one, she can have a vaginal delivery. But once she's had two, she really needs to have a caesarean every single time. If there's some disease where labour is going to be harmful to her, like we talked about before, if there's placenta previa, or if there's, or the mum has HIV. You can also do an elective Caesar with a maternal request, and that's becoming more and more common these days. An emergency caesarean section should be done when there's failure to progress or cephalopelvic disproportion that can't be fixed, or if there's fetal distress, shoulder dystocia, malpresentation, or a few other fetal causes as well. So the risks of a caesarean section are that there's an increased risk of uterine rupture in future pregnancies and of placenta accreta in future pregnancies, in addition to all the risks associated with any major surgery. So there's risk of pain, there's risk of bleeding, risk of infection. So as I said before, you can have a vaginal birth after caesarean section, but it's automatically classified as high risk. And after 2 caesarean sections, you should only have caesarean sections. So we're seeing quite a rise in caesarean sections in the last 20 years in Australia. We've gone from 1 in 5 to 1 in 3 women having caesarean sections, but we're not seeing any improvement in neonatal or maternal mortality and morbidity. What's really interesting to look at is in this graph from different income countries. In low-income countries, we can see that as caesarean section rate increases, the neonatal mortality decreases, and the same for the mum. So caesarean sections are good in low-income countries when there's not many to start with. But in high-income countries and medium-income countries, we can see there's an association between increasing caesarean section rates and actually increasing mortality for mum and baby. So it's not quite so helpful once you've reached a certain point. I'll talk a little bit about twins, but not much. The natural incidence of twins is 1 in 80, but the actual incidence is now 1 in 60. This is because mums are having babies later, so there's a higher risk of twins. And there's also increased use of IVF, which is a higher risk of multiple pregnancies. This is a problem because whilst twins only account for under 2% of deliveries, they account for over 20% of NICU admissions, so they place a big burden, and pretty much every single complication you can think of is more common in a twin pregnancy, and they come with their own complications as well, like twin-to-twin transfusion syndrome. So I'll start now on obstetric emergencies, which is the second part of this talk. Before I go into it, I think we should recap kind of how you should be approaching any acute scenario you come across. The first thing you should do as a medical student, junior doctor, is really call for help, and you should do this a few times throughout the procedure as you kind of work out what's going on. You need to make a clinical evaluation of the situation to try and work out what's going on and whether resuscitation is required. You then need to resuscitate if required, assess the underlying cause, and then manage the underlying cause. So that fits in a nice mnemonic, luckily. And afterwards, particularly in obstetrics, it's really, really important to document every single thing that's happened, because obviously it's an area people really care a lot about. There's a lot of interested parties. And it's really important you document exactly how everything happened. So in an OSCE, you definitely say, I would then document everything I've done. You would then say, I'll debrief with my team and debrief with the mum and the partner. So they're all going to be marks on the OSCE. And then if the obstetric emergency has happened antenatally, you'd also need to say, and continue normal antenatal care and follow-up. Where if it's happened at delivery, say, continue normal postnatal care and watch for signs of things like postnatal depression, which will be more common after any obstetric emergency. So antepartum hemorrhage is the first obstetric emergency I'll talk about. And this is bleeding from the genital tract after 20 or 24 weeks gestation. Different sources say different things. If you had to go with one, I'd pick 24 weeks, but I don't think they'll make you decide between them. Earlier bleeds than this are defined as a threatened pregnancy and have a different set of causes. So things like miscarriage or cervical cancer, things like that. So antepartum hemorrhage affects 5% of pregnancies, but it's associated quite strongly with preterm deliveries as well. It can be classified into just spotting, which is when there's just spots of blood on the underwear, minor, which is less than 50 mils, which is now stopped, major, which is less than 1,000 mils and no shock, or massive, which is over 1,000 mils of blood loss, or shock. So as soon as the mum goes into shock, it's defined as a massive hemorrhage, okay? The cause of antepartum hemorrhage, the two main ones you need to know are placental abruption and placenta previa, and I'll focus on them in the next slide. Other causes can include placenta accreta, vasa previa, cervicitis, lower genital tract infections, or malignancy, which still occurs in pregnant women. So placenta previa is implantation of the placenta in the lower segment of the uterus, when usually it implants in the upper segment. It occurs in about 0.5% of women in pregnancies, and it's defined into 4 different grades. Grade 1 is just a low-lying placenta. So this is when the placenta is in the lower uterine segment, but it's not really near the cervix, not really near the entrance. You can see a picture here. Grade 2 is marginal. This is when the placenta reaches the os of the cervix, but doesn't quite move over it. Grade 3 is partial, where it partially covers the os, and grade 4 is total, where it completely covers the os, as you can see. The risk factors for placenta previa are usually conditions that have been pre-existing before the pregnancy began. Things like obviously having a previous placenta previa, a high maternal age, having IVF, being multiparous, being a smoker, or sometimes having twins as well. The key risk factor though is a deficient endometrium. So this can occur because the mum might have had uterine surgery, or the mum might have had endometritis, curettage, or fibroids. Another risk factor is a previous cesarean section. Given that our rates are increasing by so much, that's obviously an increasingly more important risk factor today. So there's a dose-response relationship between having a cesarean section and the risk of placenta previa. After only 1 cesarean section, there's a relative risk of 2.6, but after 4, there's a relative risk of 22.4. So it definitely increases. The key feature of placenta previa, to differentiate it from other things, is that there's a lot of bleeding, but it's quite painless. There's an abrupt onset of bleeding and then painless. It's diagnosed in an ultrasound, and if you diagnose placenta previa, or if you diagnose a low-lying placenta early in gestation, you need to repeat ultrasound at 35 weeks. This is because a lot of low-lying placentas seem to migrate upwards as gestation progresses, and that's for a few reasons. Firstly, the placenta seems to like to grow towards the more well-vascularized upper segment of the uterus, and secondly, the lower segment expands more, and so even though it looks very close to start with, it can eventually end up quite far away. So the second major cause of antepartum hemorrhage is placental abruption. This occurs in 1% of pregnancies. This is when the placenta separates too early, and it leads to a lot of bleeding from the severed vessels, essentially. So this can be classified as either concealed, which is where there's no bleeding, but there's a lot of pain, and the uterus will feel very wooden and hard. You can see that's here. So even though the placenta has separated from the wall, we can see the blood's kind of trapped behind the placenta and can't get out of the os. So you don't notice any bleeding, but it's causing the woman a lot of pain and probably causing the fetus a lot of trouble as well. The second classification is a revealed placental abruption. This is when there's bleeding because it can get past the placenta and can get out. And the third is a complete separation of the placenta and the uterus. And this is obviously very, very dangerous because the baby's not getting any more blood supply. So the risk factors for placenta abruption are things that occur during pregnancy. As before, it's always a previous of the same thing is going to be a risk factor for any obstetric problem. Increasing age, IVF, multiparity, all sorts of things, and smoking and twins. So they're kind of things for most things. Conditions that occur during pregnancy are hypertensive conditions like preeclampsia or chronic hypertension that's worsens during pregnancy, or trauma that's obtained during pregnancy. This can either be accidental, or it could be from a car crash like a seatbelt, or it can also be due to domestic violence. So if a woman presents with placental abruption in your OSCE, given they like to tie things in, I would definitely be trying to ask one of your questions about domestic violence, however you do it. Another risk factor is chorioamnionitis, so things that are happening during pregnancy, PPROM, cocaine use, a low BMI, or an early pregnancy bleed can predict a future pregnancy bleed. The key feature of placental abruption is painful bleeding. And not only painful, because there's so much buildup of blood, the uterus becomes very tense and is often described as wooden or hard, and there's also fetal distress. Placental abruption is a clinical diagnosis because the ultrasound sensitivity is only 24%, so it misses a lot of them. So yeah, definitely a clinical diagnosis. The other causes of APH I'm not going to go into heaps, but they're placenta accreta. So accreta means adherent to the uterine wall. Increta means it invades the muscle. And percreta means it invades kind of out of the uterus and can invade other organs as well. This occurs in 1 in 2,500 pregnancies, so it's quite rare. Risk factors are prior cesarean sections, and as we said before, rates are increasing, so this is becoming more and more common. At delivery, you need to deliver in a hospital that has an ICU, that has a blood bank, and that has a multidisciplinary team available. So these are all things that's probably good to say in OSCE for any kind of severe sounding condition, because they'll probably get your marks. When you're delivering, it needs to be a cesarean section, and most women will end up having hysterectomy at the same time. If you don't want a hysterectomy, you need to embolize both internal iliac vessels. Otherwise, when the baby's delivered, it might bleed out. Another cause is vasoprevia. So this is when, as we said before, the fetal blood vessels are in the amniotic membranes below the fetus. This means that any bleed you see is going to be fetal blood rather than maternal blood. So when the membranes rupture, this can sometimes be enough to trigger a bleed, and the fetus is obviously going to die quite quickly because the fetus only has 100 mils of blood in its body. So you can imagine if you see a 50 mil bleed and you go, it's not a big problem. If it's fetal blood, that's half its blood volume lost. So vasoprevia can be diagnosed in Doppler ultrasound because when you do an ultrasound, you can turn on the Doppler flow, the color flow, and you see all these vessels kind of where there shouldn't be vessels. There's obviously vasoprevia. You can also palpate the fetal vessels if you've done a BE, or if there's rupture of membranes and sudden PV bleeding and then acute fetal bradycardia, you know it's vasoprevia. The management of vasoprevia is you don't want the woman to go into labour because you don't want her membranes rupture because that's going to kill the fetus, so you do a cesarean section before the onset of labour. Other causes include uterine rupture, which again is becoming more common after cesarean sections arising. So there's an exam question asking maybe this woman has had lots of cesarean sections before, in labour suddenly has this massive pain and lots of bleeding. That might be uterine rupture. It could be hemorrhoids that she thinks are coming from her cervix, or hematuria, again, that's being confused. Any tears in the cervix or perineum can make it look like an antepartum hemorrhage. Bleeding disorders aren't that associated with it. Cervical cancer obviously can affect pregnant women as well. And then something called ectropion. So ectropion is when the eversion of the endocervix exposes the columnar epithelium to the vaginal acidity, and so they can sometimes bleed for that. I don't know if you need to know. So the management of antepartum hemorrhage, to start with, you need to evaluate the situation, and the most important thing to look at first is the maternal hemodynamic state. The mum is still your first priority when the fetus is inside, so you need to see, does the mum, is she stable or is she not? So if she's not stable, it means something really bad has happened because the vitals don't change until you've had quite a significant amount of blood loss. So if there is hemodynamic compromise, you need to commence resuscitation immediately. So the first thing, again, is call for help, and then do IV ×2, fluids, oxygen, cross-match 4 units of blood, do an FVE, coags, UEC, LFT. So these should be things that you know how to say. And then for all women, whether it's hemodynamically compromised or not, you need to determine their rhesus status, which should have been done early in pregnancy, hopefully. And if they're rhesus negative, give them anti-D, because obviously there can be some mixing of maternal fetal blood here. You then need to put in a catheter, continue to take vital signs, and do a continuous CTG monitoring of the fetus. Perform an ultrasound and speculum examination. So it's very important to do a speculum rather than a digital examination, because if there's placenta previa, you can cause a massive bleed by doing a digital examination. So if the mum's still not stable after all this resuscitation, you need to deliver straight away, because obviously having the fetus inside is causing her harm, and the mum has to be your first priority. However, if the maternal hemodynamic state is not compromised when you first assess it, you then move on to probably a bit more slower route. You assess fetal well-being. So first of all, ask the mum, have you been feeling movements normally? Listen, so auscultate. And if you can't hear a fetal heart rate, you don't just assume the fetus is dead. You need to do an ultrasound to confirm. Ask the mum if she's in any pain, and ask more questions about the bleeding and try and determine the amount of blood lost. At this stage, you also want to ask the mum about her past history Has she had a past history of an antepartum hemorrhage? Was it a placenta previa? Was it a placenta abruption? And then also you want to ask her about her past history of pap smears, because often a woman will have had maybe a positive pap smear but just hasn't thought to tell you about it, and this may actually be cervical cancer, particularly if she isn't hemodynamically compromised. You then perform abdominal palpation, but as I said before, it's really important not to do a vaginal examination. Perform a CTG to, I guess, better assess fetal well-being, and if it's abnormal, that's an indication to deliver, because obviously the fetus is in distress in there. Then perform ultrasound and speculum, do your bloods. Apparently you don't need to do coags unless it's severe or unless there's a platelet abnormality. And as it's minor, you don't need to do cross-match 4 units, you can instead just do a group and hold. If after the ultrasound and speculum and all the resuscitation, the mum was stable, you can move kind of to this pathway as well. And if the baby is below 35 weeks, you give them a course of corticosteroids, and then reclassify the pregnancy as a high-risk pregnancy. So that requires serial ultrasounds to determine fetal growth, continuous CTG at delivery, and more frequent follow-up with an obstetrician rather than just a midwife. So it's really important that tocolysis is contraindicated in people with APH, as it can worsen the hemorrhage. And also because one of the side effects of tocolysis is an elevated heart rate, which can mask some of the signs of hemodynamic compromise. So when delivering a baby who's had, a mum who's had antepartum hemorrhage, if the baby is dead and you confirm that, allow it to come out vaginally. If there's maternal or fetal compromise, you have to do an immediate cesarean section. But if there's no compromise and they're below 37 weeks, you just consult your senior about what to do next. If they're above 37 weeks, you also need to do an elective cesarean section, but not emergency. For postnatal care of women who have had APH, there needs to be, as I said before, you need to debrief the woman and their partner, provide a contact detail for psych follow-up because any obstetric emergency can lead to postnatal depression, and provide thromboprophylaxis because an antepartum hemorrhage is a risk factor for getting a future venous thromboembolism. So the other important thing is that if they've got placenta previa, it's really important. Obviously, you're not doing any digital examinations, so they can't have intercourse as well. So you need to make sure you tell them that. So some more questions. So yeah, why don't you try this one? So a 19-year-old primary gravidator presents to the birth suite in an ambulance at 34 weeks with PV bleeding, a sudden gush. Estimated blood loss is 300 mils, hasn't attended any antenatal visits since 16 weeks. CTG showed baseline 170, variability of 3 to 5, no accelerations in 20 minutes, and late decelerations of 60 beats below baseline with slow recovery. Abdominal examination revealed a singleton fetus in longitudinal lie, symphysiofundal height 34 centimetres, and a cephalic presentation with a mobile presenting part. So look at that and tell me anything that's concerning you and what you would do next.
So she hasn't been to any care.
Mm-hmm.
So CTG, baseline bit late decelerations.
Yep. So how are you concerned, very concerned, or not concerned? Yeah, pretty concerned. So which option do you think you should do? So I'm really concerned. I think it's quite worrying. So you would do an emergency cesarean section, I think. So if there's clear evidence of fetal distress and antepartum hemorrhage, it's an indication to deliver immediately by cesarean section. Like I said before, fetal or maternal compromise, do a cesarean section. So in terms of, yeah?
If the option was there, should you give steroids before you proceed to the emergency cesarean section, or do you just take
No, take it straight up. Because the steroids are, you give steroids to the mum, and so they need time to work. And so if you're doing a cesarean section straight after, there's no point giving it to the
so
mum.
you just have to 4 months after it's later, that's going to happen anyway.
Because you've got to get the baby out, exactly. So you might consider surfactant at birth instead. So the complications of APH, there's a lot of maternal ones, a lot of fetal ones. I won't go into them, but one I think you should know is a covalent uterus. I don't actually know how to pronounce it, but that's essentially when there's bleeding into the uterine myometrium and into the peritoneum, and so the uterus becomes purple or blue. So I imagine you could get some question where it's like the uterus was purple or blue at autopsy or something like this. What went wrong? So in terms of an MCQ that might be about an antepartum hemorrhage, you could have a 28-year-old G1P0 present to 34 weeks gestation with painless ongoing bright red PV bleeding. So it's painless bleeding. So that should immediately make you think placenta previa. Okay. You could also have a 30-year-old lady presents with a single episode of large PV bleeding and abdominal pain. Uterus is contracted and tender. So large bleeding and pain, painful bleeding is placental abruption. Okay. 30-year-old had membranes ruptured. So membrane ruptured, immediately following this, small amount of blood, maybe not so bad, and sudden fetal bradycardia seems really bad. So what do you think that is? Yeah, so vasa previa. So it's obviously really bad for the fetus to lose just that small amount of blood. I'll do the first one for you. So match the clinical conditions with the relevant signs or symptoms. So labour is pain with regular uterine contractions. So Steph, what's placental abruption going to be?
Tender rigid.
Yeah, tender rigid abdomen. So it's good you were looking for painful bleeding first, but wasn't an option. So yeah, tender rigid abdomen is the next best one. And what about the next one, placenta previa? Good. Okay. So those are all buzzwords. So cord prolapse is the next obstetric emergency I'll talk about, and this occurs again in 0.5% of pregnancies. So cord presentation and ruptured membranes equal a cord prolapse. A cord presentation is when the umbilical cord is alongside or past the presenting part, but this isn't so much of an issue until the membranes rupture, and then it's a cord prolapse. So obviously, if the umbilical cord is alongside or past the presenting part, the head and the pelvis are going to be putting pressure on it, and so you get umbilical cord compression. There's also some vasospasm that occurs when things contact the cord, and these two lead to reduced blood flow to the fetus and birth asphyxia in this fetus. This can lead to cerebral palsy and hypoxic ischemic encephalopathy. So the risk factors for cord prolapse are usually, that's wrong, I just copy pasted that, don't worry about that. So the biggest risk factor is a breech birth. You can also have a disengaged fetal head, because obviously the cord can then kind of get past the head. A grand multi, as we said before, uteruses are quite floppy after a few babies, or a premature baby because it's too small and there's enough space for the cord to get alongside the head. Multiple pregnancy, again, there's a lot kind of going on in there, so the cord can get past it. Or a forceps or vacuum delivery is a risk factor because that might be the reason why it wasn't progressing. Or polyhydramnios, again, there's a big space there for things to float around in. So the clinical signs of a cord prolapse are fetal bradycardia after rupture membrane, so similar to what you would imagine with vasa previa, but there's not a bleed, and a cord palpable of vaginal examination. So in order to kind of try and prevent cord prolapse, you can offer elective admission at 38 weeks for any woman with an abnormal lie, because that will allow the cord to go past. And also to avoid it, you can not do artificial rupture membranes when the station is high, because as you can imagine, if you rupture membranes when the station is high, everything will kind of fall out because the head's not blocking the pelvis, the cord could fall out for it first. So managing cord prolapse, again, first thing you need to do is call for help and then evaluate. You need to, obviously you'll be doing an examination, so you want to see, is the cord pulsating or not? If the cord's not pulsating, that means there's no blood going through it and the fetus is probably dead. So if it's not pulsating, you need to confirm the fetal death by doing an ultrasound. And then allow a vaginal delivery to occur, and then provide counselling to the mum, obviously. If the cord is pulsating, the fetus is alive and you need to manage it. So if it happened in the first stage of labour, you proceed straight to emergency caesarean section, and obviously as you are moving the mum to theatre, obtain IV access, stop any oxytocin infusion because you don't want her to push the baby out, start oxygen, do a continuous CTG, put her in a knee to chest position, and manual elevation. So manual elevation means stick your hand in and elevate presenting part off the cord to reduce pressure on the cord, and whoever has the sad job of doing that has to maintain it until the baby's out. So for the whole trip to theatre and then for the whole operation, they've got to have their hand stuck in there. So you can consider tocolysis, but given you're doing an emergency caesarean section, you probably don't need it. The other thing you can do is fill the bladder, because by filling the bladder, that will lift the presenting part off the cord as well. After this, after delivery, take cord blood gases and pass it over to the neonatologists. I won't go into it here. I'm sure someone else has gone into what to do in a sick baby at birth. And then in the if it happens in the second stage of labour, you can consider using a forceps or vacuum, because obviously the baby started to come out already. Caesarean section might not go so well. But if this isn't feasible, then you move on to a caesarean section. So a question you might see that is about this is a 30-year-old grand multi. He's pregnant with twins, so multiple pregnancy as well, goes into spontaneous labour. First twin is delivered fine at home with a midwife, and then while delivering the second twin, the midwife notices a cord-like structure, so that kind of tells you what it is, in the vagina below the head. So that's a cord prolapse, it's a cord below the head. A more formal exam question might be, if a 30-year-old preemie of gravity is induced at 42 weeks, so she's post-term for a prolonged pregnancy. Pregnancy was complicated by mild polyhydramnios, so she's got a little bit of polyhydramnios, a little bit of space for a cord to go past, and the amniotic fluid index was 22. The vertex was fixed at the brim, but was readily palpable abdominally, so it's not so engaged. The cervix has been primed with prostaglandin the night before, so she's been induced. After the artificial rupture of membranes, the fetal heart rate was 60 beats per minute and stayed there. So after rupture of membranes, we're having a deceleration, a bradycardia, sorry, but we're not having a bleed. So it's probably not vasoprevia, but the other thing is called prolapse. So after the registrar did a vaginal examination, they obviously felt something weird because they put the woman in a knee chest position, which is a buzzword for cord prolapse, and they were taken to theatre. So that's why I would pick cord prolapse. So shoulder dystocia is the next obstetric emergency I'm going to talk about. And this occurs when essentially the fetal shoulders don't fit through the pelvic inlet. So the anterior shoulder will wedge against the pelvis following the head coming out, and further maternal efforts to push the baby out are futile. So there are some risk factors for shoulder dystocia, but it's really important to remember that it can't actually be predicted that well because 50% occur in women without any risk factors. So the maternal risk factors that are there are having a previous shoulder dystocia, like anything in obstetrics, having a prolonged labour, diabetes, or obesity. On the fetal risk factors are macrosomia, longer pregnancy, congenital abnormalities, and so obviously a big baby is a big risk factor because it can't fit out. So if you notice shoulder dystocia, delivery must occur within minutes because the head's already out but the body's not, and it's a really dangerous situation. And that's leading to the fetal pH falling by 0.04 per minute, which doesn't sound like a lot when you think about what normal pH range is. It's just 7.35 to 7.45. There's obviously not a lot of time before the fetus starts to get really acidotic. So the complications associated with shoulder dystocia are, for the fetus, it could have a fractured humerus or clavicle. It can also have damage to the brachial plexus. For the mum, there can be some soft tissue injury, and the fetus as well. There can be perineal tears or postpartum hemorrhage. So the management of shoulder dystocia are first of all to recognise that it's going on. So there's some key warning signs that you can look for, even though you can't predict it happening. So the warning signs are a slow delivery of the fetal head, delay of shoulder restitution, or the turtle sign, which is the fetal head retracting. So after it comes out, it retracts back in, which it shouldn't do. The first thing you do when you see these signs are to call for help and very clearly state this is shoulder dystocia. Every single guideline says to do that. So imagine if it was an OSCE, there would definitely be a mark with clearly stating what it is. You tell the mum to stop pushing because it's going to be futile. So you don't want to exhaust her. You don't want her to cause any more harm to the fetus by putting pressure on it. And then you can begin some manoeuvres. So each manoeuvre you should try for 30 seconds. I don't think you're probably expected to know too much about them, but the one you might need to know is the Mick-Roberts position. So this is when there's sharp flexion of the thighs against the abdomen. So essentially pulling your knees up close to your chest as you can. So you can see here that that's going to open up the pelvis more and allow those shoulders to maybe come out. At the same time, you want to apply suprapubic pressure. So this is done to kind of squish the shoulders and kind of squeeze them out the pelvis. It's very important that you apply suprapubic pressure and not fundal pressure, because fundal pressure will cause to kind of just impact it more and cause more distress to the fetus. If this doesn't work, you can move on to internal maneuvers. There's a lot of them. I'm not going to go into them, but essentially they all involve performing an episiotomy, inserting a hand, and performing the internal maneuvers, one of which is pulling the posterior shoulder out first. If these don't work, you can put the mum in an all-fours position, as that may help gravity pull the baby out. And if none of these work, there's something called a Zavanelli maneuver, which is when you push the baby back in and then do a cesarean section. So that's the last resort. It's important to delay the cord clamping if there's shoulder dystocia, because while the baby's shoulders have been stuck, there hasn't been a lot of blood getting to the baby. And just because of the way the umbilical cord works, a lot of it's probably backlogged into the placenta. So when the baby comes out, you really want to make sure there's as much time as possible for the placenta to continue to provide some blood to the baby. If you need to cut the cord for some other reason, you should try and milk it first. So kind of clamp the placenta and then try and push all the blood towards the baby and do that a few times. And it's very important, obviously, for the neonatologist to review the baby as soon as it comes out. So you should be calling them at the start as well as the obstetrician, midwife, and anaesthetist. Some key things to remember when managing shoulder dystocia are to avoid excessively pulling, to avoid placing pressure on the fundus, as I described before, and to make sure when you're twisting things not to twist the fetal head because you could really hurt its neck, but instead to twist the shoulders. So a question you might see, which has kind of every buzzword you could think of, is prolonged second stage, which is a risk factor. On delivery of the head, there's failure of restitution, another sign, warning sign, and the baby's head appears to pull back, so that turtle sign. They've had gestational diabetes, so it's a big baby, and mum's big as well. So shoulder dystocia. Okay, a more formal question again might be, again, you can see kind of the same signs being described here. So gestational diabetes, so big mum, big baby, delaying the long second stage, head delivered, but then the head retracted. So again, it would be shoulder dystocia. So I'm not going to go into amniotic fluid embolism because didn't quite have time in this time frame. But essentially the buzzword you're looking for is fetal screams in maternal lungs. So if there's a question with that, that's what the answer will be. I will go into postpartum hemorrhage because I think it's a quite important area, and they're always quite likely to put it on an OSCE because there's different aspects of its management that they can assess in an OSCE form. So the definition of a PPH is blood loss of over 500 mils, and a severe PPH is over 1,000 mils after delivery. Primary is within 24 hours from birth, and secondary occurs after a day but within 6 weeks. It's important to look for, because you can't always measure exactly the blood loss, look for excessive bleeding postpartum and look for maternal hemodynamic compromise, as PPH is most often the cause. The 4 causes of PPH are tone, trauma, tissue, and thrombin. So tone is uterine atony, so a lack of tone. Trauma can be either external or internal. Tissue is retained placenta, and thrombin is maternal coagulation disorders. So uterine atony is a boggy enlarged uterus above the umbilicus, so that's what you'd be feeling for. So you'd recognise it. Trauma is always visible on speculum or the mum might complain of peritonism, so pain. Tissue, as you apply final pressure, you may expel some tissue. So you can see there's obviously more tissue in there. And also when you pull the placenta out, you should check it's complete. And if it's not complete, again, there's probably some more placenta left in there. Thrombin, you diagnose based on the clotting profile and on the past history, but that's probably a less likely cause compared to the others. So the risk factors for uterine atony are huge. I won't go into them, but they're essentially anything that's going to lead to an overdistended uterus, so multiple pregnancy, polyhydramnios macrosomia, or anything that's going to lead to a lack of tone in the uterus, which might be anesthetic or tocolytic, which reduces contractions and hence reduces tone. Trauma, the risk factors are quite obvious again, an operative delivery or any lacerations they've sustained. Tissue, risk factors are if there is any retained placental tissue, or if there's a morbidly adherent placenta, or if they've had any history of adherent placenta or placenta accreta. The risk factors for maternal coagulation disorder are if they have a maternal coagulation disorder or if there's anything that runs in the family. But again, the biggest risk factor is if they've had a previous postpartum hemorrhage. So again, everything repeats itself in obstetrics. So thinking about why uterine atony occurs, normally after delivery, the uterus contracts and all the blood vessels that were supplying the placenta are compressed, and so there's no bleeding. But if the uterus has a lack of tone, these blood vessels aren't compressed and they just bleed straight from maternal circulation into the uterus, which is a huge cavity. So you can imagine all the blood in the body will eventually just come out. That's not good. So again, when we're managing PPH, call for help, evaluate the situation, resuscitate, assess the underlying cause, thinking about the tone, trauma, tissue, and thrombin, and then manage the underlying cause. Begin with medical management and then proceed to surgical management if it doesn't work. We'll go into what those managements are. When thinking about clinical evaluation, you start with a history, you start with things about the mum. What's her age? What's her pregnancy history? Does she have any medical problems? Then you ask questions about the current pregnancy. Did anything go wrong in the antenatal period? And what gestation is the baby now? Ask about the labour. So how's it been going? Did anything go wrong? How was she contracting fine? Was the fetus fine on CTG? Was there induction? And then ask about the delivery itself. So what was the presentation? Was it an instrumental delivery? Was an episiotomy performed? Because that's a risk factor for PPH. And during the third stage, how long did it last? Was it actively managed? Or in some places, you can still elect to have it physiologically managed. And at delivery, was the placenta whole? You then ask questions about the baby. So is it a singleton or a twin? What were its APGARs at delivery? And then ask questions about the bleeding. So try and estimate the loss, see if there's any clots in the bleeding, and assess any dyspnea or dizziness. Then proceed to examination, where you're essentially really interested in the mum's conscious state and in her hemodynamic state. So the resuscitation, you all know because you've done it in the third year, is assess danger first. So obviously use precautions when you're handling any bodily fluids like blood. Response, so assess the mum's conscious state. send for help. We've talked about calling for help a lot. Airway, so assess and maintain your airway, breathing, circulation. So when you're managing circulation, one of the key things you can do is tilt the bed so it's head down, and that's going to reduce the blood loss. Put her in a left lateral position while she's tilted down as well will help. Obviously put in IV cannulas ×2 and then fluid replace. Because if it's a severe hemorrhage, cross-match 4 units of blood and insert a urinary catheter to continue maintaining, recording her fluid balance. So the investigations you need to perform at this stage are an FBE, cross-match, obviously we talked about, coagulation studies, and a fibrinogen as well. So the next step is to assess what's going wrong. So we talked a little bit about tone, trauma, tissue, and thrombin, and about how we can recognize each thing. So we talked about that already. And then you need to manage the underlying cause. So if it's a problem with uterine pain, you begin with massage and then give uterotonics to try and increase the tone of the uterus. Then perform bimanual compression, and then take, if that doesn't work, take her to theatre. So see, we're kind of stepping up our manage here. I'll go through what the uterotonics are in a second. If the cause is due to trauma, you just apply pressure, because applying pressure to something that's bleeding is going to stop it bleeding, and take the lady to the theatre if she continues to bleed. If she's continuing to bleed and you're applying pressure, it's not working, you can give them a mum general anaesthetic, and then you can properly examine the entire genital cavity and also the uterus as well for any signs of bleeding. If the cause is due to tissue, a bimanual compression will also reduce the bleeding, but you always need to take her to theatre to remove the products of conception. If the cause is due to thrombin, obviously investigate any coagulation studies. So when managing uterine Aidan, I'm not going to talk so much about the others because this is the most common one. You begin with simple management. So simple management is putting in the urinary catheter, because in this case, unlike with the cord prolapse, we actually want to reduce the amount of urine so that there's less pressure. So that there's more pressure on the uterus. We need to a fundal massage can stimulate contractions, so it can cause the uterus to increase its tone, and bimanual compression can apply that pressure itself without requiring the uterus to. Then proceed to medical management and then surgical management. So that's bimanual compression, which is lovely. So the first stage in medical management of postpartum hemorrhage is ergometrin. So ergometrin can be given as 250 micrograms intramuscular or IV. I've listed some side effects here. I won't go through them, but it'll be good for you to look at later. The alternative is symptometrin, which is ergometrin with oxytocin as well. So these are the first line drugs. Remember, this is after active management of the third stage, so they've already got oxytocin, and they may have also got ergometrin if they're a high risk. Second option is then oxytocin. You give a 10 international unit bolus and then follow that up with 40 units per litre infused at 10 units per hour. Okay? Third stage is misoprostol, which is given PR. And the fourth is prostaglandin F2 alpha, which is given straight into the myometra in the uterus. So injection straight in. So Stephanie Jones had a normal vaginal birth 1 minute ago. No antenatal complications. First stage was 8 hours and second stage lasted 2 hours. She did not receive any medications at or just before delivery. What medication will you consider next? So anyone want to answer? Yeah, so YE, what's that doing? Yeah, so it's active management. Perfect. Cool. So E, so the first thing to do is oxytocin 10 units intramuscular. Now, after the placenta was delivered, she had a sudden gush of blood, about 800 mils, so that's a postpartum hemorrhage. You massage the uterus first, you attempt fluid resuscitation, but it's not working. What medication will you consider? So she's had active management of the third stage already. What's the first line for PPH? Yeah, perfect. So ergometrin. Now you managed to control this bleeding and her overall blood loss was 1,200. But you feel concerned that she may bleed again. So you want to continue giving her something to increase the tone of her uterus essentially. So what will be your drug of choice now? So she's had 10 units oxytocin. She's had ergometrin. What's next? So you whispered it? Yeah, which one?
Well, we said the bolus and then the form.
Yeah, so it's not on there, but I think the key thing here is they said continue treatment with some medication, so that would probably not include, it makes me lean more towards the infusion rather than the bolus. But you're right, you would give a bolus and then start the infusion. I think the order of that doesn't actually matter so much though, so maybe it is fine for it to do the infusion and bolus at the same time, okay? Yeah, the key thing was continue treatment. So if medical management of PPH doesn't work, you move on to surgical management. So you move the woman to the theatre, do a general anaesthetic and examine her under anaesthetic, because as we said before, any problems with the tissue or with the trauma needs an anaesthetic examination. In theatre, you can give the woman prostaglandin F2 alpha, so that's an injection straight into the uterus, like I said. You can try a Bakri balloon, which is shown here. So it's essentially a catheter with a big balloon on it that you can pump up to apply pressure to the uterus from the inside. Or you can perform a laparotomy. So this is obviously getting much more invasive. Try manually put pressure on the uterus. Try things like a B-Lynch suture, which is shown here, and is designed to compress the uterus as much as possible. Ligate both uterine arteries to stop blood getting there. And then as a last resort, a hysterectomy is the final line. So before putting them under general anaesthetic, because they may wake up from general anaesthetic without a uterus, it's obviously very important to warn them, maybe consent them and say, look, if it comes to it, this is what we might have to do, so that she can tell you her views on that or something like that, okay? So in subsequent pregnancies after a PPH, you need to ensure that the mum gives birth in hospital, because as we said before, one of the biggest risk factors for PPH is a previous PPH. So she needs to be in a place where she can get the appropriate management. She must have active management, so she can't elect to have physiological management. So we talked about what active management was. She needs to have IV access during labour, so if something does happen, you can immediately try to correct the problem. Do FE agreement hold at the start of labour where it's less kind of urgent, so you've got more time to run it. Make sure there's an experienced doctor present at the delivery. Make sure you've got all the drugs you need. So you need ergometrin, you need misoprostol, and in theatre you need prostaglandin F2 alpha. So this would be kind of the ideal answer in endoscopy. So on an MCQ, you could see 30-year-old G1P1, just given birth, had physiological management, so it's already a red flag, starts to feel drowsy, and the bed's covered in blood, so it can't really be anything else, it's PPH. On a more difficult exam question, we can see there was a prolonged second stage, no antenatal complications, but a big fetus. She had intramuscular symptometrin for management of third stage of labour, which was repeated, but is still bleeding. So she's already had her active management. She's had her first management of PPH. So again, what's next in line? It'll be the oxytocin, okay? In this one, it's even easier because there's no option for bolus. There was just infusion of 40 or infusion of 10. So this is a monash exam question, so it shows that you do actually need to know which dose to use. So it's a bolus of 10, infusion of 40. Yeah?
With that, if someone was still bleeding, like taking infusion might take a while to give them medication. Do you wait to see if it works, or would you still go to the medication?
So yeah, it depends on kind of if she's still heavily bleeding. Obviously, you wouldn't just wait to see if it's working. You move on to misoprostol, move on to prostaglandin F2 alpha in theatre. If it looked like it was decreasing, then yeah, maybe you could justify waiting a little bit, but that's completely dependent on the situation. So if in an OSCE, if you said begin an oxytocin infusion of 40 international units per liter and they said she's still bleeding, you would definitely say do something else. You wouldn't just say, oh, let's just wait and see. So what rare endocrine syndrome is a complication of severe PPH? So Sheehan syndrome, so that's a good bio question, I think. So that's the clinical scenario would be mum presents unable to lactate for her baby after having a PPH that she then recovered from. And so the answer would be Sheehan syndrome. So this is when after a severe hemorrhage, mum's obviously lost a lot of blood, and then you can have avascular necrosis of the pituitary, and that can lead to pituitary deficiency and hence failed lactation. So I'll put my slides up later. Okay, so that's what I wanted to go through. So I think we've kept to time, which is good. I know you all want to go home. So I thought I'd give some tips for the rest of fourth year and then the future as well. So it's really, really important. This is one of the best things for me to form a study group with a few other people. Try and meet up every week now before the Y. You don't really have that much longer to go. It's best just to put in the work now in the next couple of months. Start doing practice fires now. Don't get scared of them. But when you're doing them, you really need to identify which questions come up very commonly, especially the question stems are often quite similar, and which questions are really, really hard. Then those questions you should delegate to different members of the group to prepare a big presentation on how to answer that question best. Come back together, and then you learn a lot more that way than you would just going through it by yourself. And you also, there's, I guess, an expectation for you to do something rather than if you're just going off yourself and setting your own deadlines, sometimes you don't do them. If you've got other people to present to, it's definitely something to push you forward. It's also really important to start doing practice OSCEs now. Again, it may seem like it's a few months away, but it'll go very, very quickly. And if you start preparing now, you'll be much more prepared for your OSCEs. Where possible, maybe not at this stage, but in a couple of months, try to book a couple of rooms in Menzies or in MMC and try to rotate through stations with a group of 5-6 people, just like a real thing, just so you're more prepared on the day and you feel more comfortable. I'm doing a BMSI this year, and even though my project's really not going to plan at all, it's still one of the best decisions I've ever made. I'm loving this year, all the freedom it brings, kind of, I can manage what I do when I do things, kind of, I've got a lot of input into what's going on in the project, so that's something you don't really get in the rest of medicine, so I definitely encourage anyone considering it to do a BMSI. I think you can still apply for the next couple of weeks. Try, maybe not for the rest of this year, but in future years, try and get involved in things as much as possible. If any of you are interested in global health kind of things, I'm running a conference called Change and Unzipped, which is a collaboration between Monash, Melbourne and Deakin. So hoping to continue in future years. This year, one day will be held at International House at Melbourne and one day will be held at Deakin. So it would be great for you to come along. There's links to that in my presentation. And last of all, if you're not playing Pokemon, what are you doing with your life? Thank you.
Really good lecture. Yeah, I thought you kept it, said everything that was like really helpful. I just want to make it. I did the neuro one last year. Yeah. Yeah, no, it was really good time. Let's stop this.